Welcome, everyone. Today we're going to talk about Toxoplasma gondii, one of the most widespread parasites affecting both humans and animals. Let's start with a quick overview. This diagram you see here shows several parasitic diseases that affect the central nervous system, and among them is toxoplasmosis, the disease caused by Toxoplasma gondii. Now, a bit about the name. The word toxoplasma comes from toxin, meaning arc or bow, referring to the organism's distinctive curved shape. The second part, gondii, comes from the North African rodent Tenodactylus gundi, from which the parasite was first isolated. It's a remarkably common organism. Roughly 1/3 of the world's population has been exposed to it. Section 2, Morphology. Now, let's begin by looking at the structure and forms of Toxoplasma gondii. It exists in three main forms: the tachyzoite, the tissue cyst, and the oocyst. In its life cycle, the trophozoite may exist as either a tachyzoite, which is the rapidly multiplying form seen in acute infection, or as a bradyzoite, the slow-growing form found within chronic tissue cysts. 1. Tachyzoite. The tachyzoite is crescent-shaped, about 4 to 8 micrometers long, and it has a single central nucleus with an apical complex used for invading cells. These forms multiply very rapidly and can infect almost any nucleated cell in the body, except, interestingly, red blood cells, because they lack a nucleus. 2. Tissue cyst. The tissue cyst form contains many bradyzoites, the slow-growing forms that appear during chronic infection. These bradyzoites are slender, crescent-shaped, and can remain dormant for years, especially in muscles and the brain, though they may occur in other organs as well. 3. Oocyst. The oocyst is the environmentally resistant stage. It's shed in cat feces, and it's typically spherical or ovoid, around 10 to 12 micrometers in diameter, with a thick double wall. When it becomes sporulated, each oocyst contains 2 sporocysts, and each sporocyst holds 4 sporozoites, giving a total of 8 infectious sporozoite. Section 3, Life Cycle. Toxoplasma gondii has a complex life cycle, involving both sexual and asexual phases. The sexual cycle occurs only in cats, the definitive hosts, while the asexual cycle occurs in intermediate hosts such as humans and other warm-blooded animals. Let's walk through the feline cycle step by step. Step 1. Ingestion of tissue cysts. When a cat eats an infected rodent, it ingests tissue cysts containing bradyzoite. Inside the cat's intestine, these bradyzoites are released and begin invading the epithelial cells. Step 2. Multiplication and gametocyte formation. Inside these intestinal cells, the parasites multiply asexually, that's schizogony, and then differentiate into male and female gametocyte. Step 3. Fertilization and oocyst formation. When the gametes fuse, fertilization occurs, forming a zygote, which develops a rigid wall, the oocyst. Step 4. Shedding and maturation. These oocysts are shed in cat feces. At first, they're unsporulated and non-infectious. They need 2 to 3 days in the environment to mature. Once sporulated, they contain infectious sporozoites and can persist for up to 1 year in soil or water. Step 5. Infection of new hosts. When humans or other animals accidentally ingest these oocysts, for example, from contaminated food, water, or soil, they become infected intermediate hosts. Modes of transmission. So, how does Toxoplasma gondii infect humans and animals? There are several routes, depending on the form of the parasite. 1. Ingestion of sporulated oocysts. This occurs when people come into contact with contaminated soil or cat litter, or consume unwashed vegetables or contaminated water. 2. Ingestion of tissue cysts. Eating undercooked meat, especially pork, lamb, or beef, containing tissue cysts filled with bradyzoites is another major route. 3. Blood transfusion and organ transplantation. Tachyzoites, the actively dividing forms, can be transmitted through infected blood or transplanted organs. 4. Transplacental transmission. If a woman becomes infected during pregnancy, tachyzoites can cross the placenta and infect the fetus, causing congenital toxoplasmosis. 5. Laboratory accidents. In rare cases, laboratory workers may become infected when handling infectious materials. Globally, transmission occurs mainly through undercooked meat, followed by contaminated water or soil. Pathogenesis and infection in humans. Once infection occurs, either from oocysts or tissue cysts, sporozoites or bradyzoites are released in the intestine. They invade epithelial cells and transform into tachyzoites, the fast-multiplying stage. In blood transfusion, related toxoplasmosis, infection occurs when tachyzoites in donor blood enter the recipient's body, invade host cells directly, multiply, spread through the bloodstream, without the intestinal phase. These tachyzoites multiply by endodiogeny, a special form of internal budding, and spread through lymph and blood to distant organs, especially the brain, eyes, muscles, and liver. Inside cells, the parasite forms a protective parasitophorous vacuole that shields it from destruction and allows continuous replication. Eventually, the host cell ruptured, releasing tachyzoites that invade nearby cells, leading to cycles of infection and tissue damage. Over time, tachyzoites convert into bradyzoites, forming tissue cysts that remain dormant for years. Summary of the life cycle. 1. Habitat. Obligate intracellular parasite found in nucleated host cells. 2. Definitive host, cats. 3. Intermediate hosts, humans and other mammals. 4. Infective stages, tachyzoite, tissue cyst, and sporulated oocyst. Clinical aspects. When a person first becomes infected, about 90% of cases are asymptomatic, meaning they show no signs. A minority may develop mild symptoms such as lymphadenitis, retinochoroiditis, or rarely, myocarditis or myositis. In most people, infection becomes latent, with tissue cysts forming in the brain and muscles. However, if infection occurs during pregnancy, the parasite may cross the placenta and cause congenital toxoplasmosis, which can severely affect the fetus. In immunocompromised individuals, such as patients with AIDS, cancer, or transplant recipients, the dormant cysts can reactivate. Bradyzoites then transform back into tachyzoites, multiply rapidly, and invade brain tissue, causing toxoplasmic encephalitis, which can be life-threatening. So, to summarize, acute infection tachyzoites spread throughout the body. Latent infection, tissue cysts form and remain dormant. Reactivation, cysts rupture when immunity is low, releasing tachyzoites again. Pathogenicity and clinical features of Toxoplasma gondii. Let's begin with the two major clinical settings in which this parasite manifests: infection in immunocompetent individuals and congenital toxoplasmosis. 1. Toxoplasmosis in immunocompetent patients. Now, when infection occurs in a person with a normal, healthy immune system, the good news is that most cases are asymptomatic. However, when symptoms do occur, they tend to be mild and self-limiting. The most characteristic finding is lymphadenopathy, particularly cervical lymphadenopathy, that is, swelling of the lymph nodes along the sides of the neck. In addition, some patients may experience mild systemic symptoms such as headache, general malaise, fatigue, and occasionally a low-grade fever. 2. Congenital toxoplasmosis. Now, let's turn our attention to a far more serious scenario, congenital toxoplasmosis, which occurs when a mother acquires Toxoplasma gondii infection during pregnancy. Interestingly, the mother herself is usually asymptomatic. She may not feel ill at all, but the parasite can cross the placenta and invade the fetal tissues, leading to significant consequences. A key concept to remember is this. As pregnancy progresses, the likelihood of transmission increases, but the severity of fetal damage decreases. So, an infection early in gestation may be devastating, whereas one late in pregnancy may transmit more easily but cause milder disease. Outcomes of congenital toxoplasmosis. We can group the possible outcomes into three main categories. A. Fetal loss. In severe early infections, the fetus may not survive. This can result in abortion or stillbirth. B. Symptomatic in the first year of life. Some infants survive but are born symptomatic. Here we see the classical clinical picture of congenital toxoplasmosis, which includes the classic triad. 1. Retinochoroiditis, inflammation of the retina and choroid, often leaving a characteristic chorioretinal scar. 2. Intracranial calcifications, visible on CT scans. 3. Hydrocephalus, due to obstruction of cerebrospinal fluid pathways. These are often accompanied by CNS abnormalities such as psychomotor retardation, seizures, or other neurological deficits. In severe cases, the outcome may even be neonatal death. C. Asymptomatic in the first year of life. Finally, some infants appear healthy at birth. No symptoms, no obvious abnormalities. However, this doesn't mean the story is over. Many of these children may later develop ocular disease of toxoplasmic retinochoroiditis, months or even years after birth. Others, fortunately, remain asymptomatic for life. If you look at the clinical photographs, you see the large, rounded head due to hydrocephalus, and on the CT image, those bright white specks represent calcifications. The ophthalmoscopic image shows the typical chorioretinal scar of toxoplasmic retinochoroiditis, toxoplasmosis in immunocompromised patients. Now, as you already know, Toxoplasma gondii infection is usually silent in healthy individuals. However, in patients with defective T-cell mediated immunity, this infection can reactivate and cause severe disease. Let's look at who's most at risk. AIDS patients, especially when their CD4 count drops below 200 cells per microliter. That's the critical threshold. Below this, the immune system loses control over latent infections. Organ transplant recipients, who receive immunosuppressive drugs to prevent graft rejection. Patients with hematologic malignancies, such as leukemia or lymphoma. And finally, individuals on corticosteroid or cytotoxic therapy, which suppress immune surveillance. Now let's move to how the disease develops in these patients. In immunocompromised hosts, the tachyzoites, the rapidly multiplying forms of toxoplasma, become reactivated from dormant tissue cysts. Once reactivated, they disseminate widely throughout the body, but they have a particular affinity for the central nervous system, the retina, and the placenta. Inside these tissues, the parasite invades host cells, multiplies, and causes cell death and focal necrosis, surrounded by an acute inflammatory reaction. This localized tissue destruction is what gives rise to the clinical manifestations we'll see shortly. Mechanism of disease. So, what exactly drives this pathology? There are three major mechanisms at play. 1. Reactivation of latent infection, tissue cysts rupture, releasing tachyzoites that multiply uncontrollably. 2. Direct invasion. The parasite directly damages tissues, particularly the brain, causing necrotizing encephalitis. 3. Secondary pressure effects. Inflammation and edema compress surrounding brain structures, worsening neurological symptoms. Commonly involved site. Now, when we talk about toxoplasmic encephalitis, the hallmark manifestation, certain areas of the brain are preferentially affected. These include the brainstem, the basal ganglia, and the pituitary gland. This localization helps explain many of the characteristic neurological signs we see in these patients. Toxoplasmic encephalitis is the most common clinical form of toxoplasmosis in immunocompromised individuals. Clinical manifestations of reactivation. The main clinical syndromes that appear during reactivation. 1. Toxoplasmic encephalitis. Patients typically present with fever, altered mental status, and even personality changes. Convulsions. 2. Retinochoroiditis. The retina is another favored site for reactivation. Patients experience ocular pain and decreased visual acuity, necrotizing retinal lesions, and occasionally optic nerve involvement, seen in about 10% of cases. Interestingly, retinochoroiditis coexists with toxoplasmic encephalitis in approximately 63% of patients, emphasizing that ocular and cerebral lesions often occur together. 3. Pneumonitis. When the infection involves the lungs, we may see cough, dyspnea, and, in severe cases, respiratory failure. 4. Disseminated disease. In its most severe form, toxoplasmosis can spread systemically, affecting multiple organs, producing a sepsis-like picture with widespread inflammation and organ failure. The diagnosis of toxoplasmosis can be approached through 2 major strategies. 1. Indirect detection, identifying the host's immune response to the parasite, mainly through serology. 2. Direct detection, demonstrating the parasite itself, its antigens, or its DNA in patient specimens. Which one do we use? It depends on who the patient is. In immunocompetent individuals, where antibody production is intact, we rely primarily on serological tests. In immunocompromised or fetal infections, where the immune response may be weak or absent, we turn to direct methods, such as PCR, microscopy, or histology. 2 specimens commonly used. Depending on the clinical presentation, we may use blood or serum for antibody or DNA detection, amniotic fluid for prenatal diagnosis, cerebrospinal fluid in cases of suspected toxoplasmic encephalitis, tissue biopsies from brain, lymph nodes, or placenta. Now, the mainstay of diagnosis in most cases is serology. This helps us determine whether a patient has been recently infected or has an old, latent infection. Let's review the key antibodies and what they tell us. IgM antibodies. First to appear after infection, usually within 1-2 weeks. Indicate recent or active infection. IgG antibodies. Appear within 2-3 weeks of infection. Levels rise and then persist for life, indicating past exposure and immunity. IgG avidity test. This test measures the strength of binding between IgG antibodies and the antigen. Low avidity recent infection. High avidity infection occurred long ago. Sabin-Feldman dye test. Gold standard but rarely used in routine labs. Detects antibodies that inactivate tachyzoite. The Sabin-Feldman dye test is a classical gold standard serological test for detecting Toxoplasma gondii antibodies. It involves mixing live tachyzoites, complement, and the patient's serum, then incubating at 37 degrees Celsius for 1 hour. After adding methylene blue, the mixture is examined microscopically. If antibodies are absent, the tachyzoites take up the dye and appear blue, whereas if antibodies are present, they damage their membranes and prevent them from taking up the dye and remain unstained. Although highly specific, the test is rarely used today because it requires live parasites and specialized laboratory conditions. Direct detection methods. Now, let's shift to direct detection. These are crucial in immunocompromised and congenital cases, where antibody responses may be absent or misleading. Molecular diagnosis, PCR. This is now the gold standard for direct detection in many settings. PCR can detect T. gondii DNA in blood, CSF, Amniotic fluid or tissue samples. Advantages: highly sensitive and specific, detects even small amounts of parasite DNA, crucial for diagnosing fetal infections and toxoplasmic encephalitis in AIDS patients. Microscopic demonstration. We can directly observe the parasite, tachyzoites or tissue cysts in stain smears, histological sections or tissue aspirate. Isolation of the parasite. Historically, Toxoplasma was isolated by inoculating mice or culturing in cell lines from clinical samples. Here we can see the main stages of Toxoplasma gondii under the microscope. On the top left are the tachyzoites, stained with Giemsa. Next, the tissue cyst, stained with hematoxylin and eosin. At the bottom, we have two forms of oocysts, the unsporulated oocyst and the sporulated oocyst. Diagnosis of congenital toxoplasmosis. This is where diagnostic precision becomes absolutely vital. If a pregnant woman is IgM positive and IgG low avidity, we suspect recent infection, possible risk to the fetus. Amniotic fluid PCR can confirm if the fetus is infected. After birth, the detection of toxoplasma-specific IgM or IgA in the infant's serum confirms congenital infection, since these antibodies do not cross the placenta. IgG, on the other hand, can be maternal and therefore isn't diagnostic in the newborn unless it persists beyond 12 months. 6. Diagnosis in immunocompromised patients. Here, serology is often unhelpful, since these patients may not mount a significant antibody response. So, we rely more heavily on PCR, neuroimaging, and histopathology. PCR of CSF or brain biopsy confirms the diagnosis of toxoplasmic encephalitis. MRI or CT scans often show multiple ring-enhancing lesions, especially in the basal ganglia. These findings, in combination, are highly suggestive of reactivated toxoplasmosis. The treatment of toxoplasmosis varies by patient type. In immunocompetent patients, therapy is only needed if symptoms are severe or persistent, using pyrimethamine plus sulfadiazine. In pregnant women, spiramycin is used for acute infection before 18 weeks of gestation, while after 17 weeks, pyrimethamine, sulfadiazine, and folinic acid are given. Ocular toxoplasmosis is treated with the same combination plus prednisolone to control inflammation. Congenital toxoplasmosis in neonates is treated with daily oral pyrimethamine, sulfadiazine, and folinic acid for 1 year. Immunocompromised patients receive pyrimethamine, sulfadiazine, folinic acid, and prednisolone. Supportive therapy always includes folinic acid to prevent pyrimethamine-induced bone marrow toxicity, and prednisone-prednisolone may be added for severe ocular inflammation or massive cerebral edema, but never alone without antiparasitic drugs. Prevention of toxoplasmosis. Prevention focuses on avoiding infection through good hygiene and screening practices. It includes eating only well-cooked meat, maintaining proper hygiene for food and water, and ensuring thorough hand washing, especially for individuals handling cats. Regular antenatal screening, particularly the torch test, is recommended for women of childbearing age to detect toxoplasma infection early. Additionally, screening of blood banks and organ donors for antibodies is essential to prevent transmission through transfusion or transplantation. Here we come to the end of this lecture on Toxoplasma gondii. Thank you all for your attention and listening.